Okay, so today we're talking about psychological disorders from a historical perspective. We're going to talk about classification systems and models or perspectives. And of course, this is a difficult issue. How do we define normal and abnormal? How do we deal with the stigma associated with diagnosis of a psychological disorder? We'll look at how modern classification systems deal with these issues and some critiques of the current system. We will also attempt to place diagnosis in a historical perspective. So psychologically ordered versus disordered thinking is a hard thing to define. First, we have to realize that it is not an either-or situation. This can be most clearly seen in the autism spectrum, for example, where normal functioning can be seen even in the presence of the disorder, or functioning can be severely restricted. The same can be said for other diagnoses such as schizophrenia, depression, anxiety disorders, etc. And there are several proposed definitions. Some of them focus more on personal distress, impairment of the ability to function. Others look at what is atypical, disturbing, or maladaptive. And still others look at what is distressful, irrational, the statistical rarity of the behavior, and the discomfort that it causes others. And so we have to clarify the distinction between sanity and insanity and psychological disorders. Sanity and insanity are legal rather than psychological terms. In most states, the legal definition of insanity relates to the ability of the defendant to distinguish right from wrong. This requires an either-or determination on the part of the court. And most psychologists reject this kind of dichotomy, seeing psychological health rather as more of a continuum. So again, sanity and insanity are not psychological terms, they are legal terms. And then looking at the historical perspective, the first question of course has to be why worry about the historical perspective at all? Well, there's two very good reasons. First, we have to recognize that defining and understanding and treating abnormal behavior has concerned humans across time and culture. And we can look at various examples of this. In ancient Greece, Hippocrates had argued that mental illness was a natural phenomenon rather than supernatural. Galen had divided causes of mental disorders into physical and psychological. And the same thing was happening elsewhere in the world, especially in China. At the same time, towards the end of the Han Dynasty, Cheng Qing was talking about disorders being medically based, organ pathologies, and psychologically induced. During the Middle Ages in Europe, abnormal behavior was frequently viewed as demonic possession. Sort of scientific approaches to understanding these behaviors faded away during this time period. Whereas in Islamic regions, a lot of progress was being made in treatment and in diagnosis. There were humane mental hospitals for, at the time, what they called the deranged. The Persian physician Ibn Sina wrote the Canon of Medicine, in which he argued for a sort of a rudimentary scientific method in treating these disorders. With the Renaissance in Europe, we get sort of a re-emergence of a scientific approach, and we see that people like Teresa of Avila in Spain establishing a conceptual framework that the mind itself can be sick. In Germany, Johann Wehr and Reginald Scott in England were using scientific skepticism to refute this idea of demonic possession, or that disordered behavior was supernatural in basis somehow. In the early modern period, we get a lot of humanitarian reforms. One of the leaders of this was Philippe Pinel in France, who established, again, humane hospitals for the treatment of mentally ill patients. William Tuke in England developed a training program for nurses to deal with the mentally ill. He helped to change attitudes regarding how they should be treated, not as criminals, for example. And in the United States, Benjamin Rush also encouraged humane treatment of the mentally ill and established the first mental hospitals in the United States. In the 20th century, of course, there have been huge advances in technology. Things such as MRIs and PET scans have really helped us to look at what's happening in the brain and establish biological basis for psychological disorders. Psychopharmacology has helped us to provide medical treatments, drug treatments for psychological disorders. So the second reason that we have to understand this in a historical perspective is to understand that more modern approaches that we see today seek to control for cultural bias, shifting the focus from what is outside cultural norms and towards what is distressful or maladaptive, harmful or unhealthy for the patient themselves. And doing so has helped to provide more effective treatments for those suffering from these disorders. So there are a number of models or perspectives for understanding psychological disorders. The biopsychological model is maybe today's sort of typical approach. This model argues that disorders have a basis in biology, which can have either genetic or environmental causes, or more likely both, and can be treated medically, typically through drugs and medications. An older model, the psychoanalytic model, focused on Freud's theory of unconscious conflict, therapy centered on talking cures, and bringing the conflict to the level of awareness in order to resolve it. Although psychoanalysis or psychoanalytic therapy is not widely practiced today, it is getting some renewed attention, particularly in the area of neural basis for cognition and brain changes and changes in neural pathways. The behavioral model, established by Watson and Skinner, argues that disorders have a basis in learned behavior. As such, therapy in this model centers on identifying the learned cause and then counterconditioning or causing extinction of the behavior. While strict behavioral therapy has faded, the model has been incorporated into more current therapies such as CBT or cognitive behavioral therapy. As we have discussed previously in this class, the behavioral model ignores or at least downplays cognitive thought processes. The cognitive model sort of does the opposite. In this model, diagnosis focuses on maladaptive or irrational thought processes as the cause of the behavior. Therapy, therefore, focuses on changing the thought process associated with the disorder. This is widely practiced today, although it seems to be transitioning into a more eclectic approach, such as CBT. The biopsychosocial model is very much a blend of best practices from other models. Diagnosis focuses on a combination of biological causes, such as genetics and environment, psychological factors, such as learned behavior and thought processes, and social factors, such as cultural expectations or traumatic events. And therapy usually includes a combination of medication along with behavioral or cognitive therapy. So the next problem, after defining abnormal, is to try and classify disorders. The first question is why the need to classify? Well, first and foremost is the need for accurate and appropriate diagnosis. In order for patients to receive appropriate treatment, there must be an accurate diagnosis that is based in sound research. This, of course, necessitates a common vocabulary, and the Diagnostic and Statistical Manual of Mental Disorders, or DSM, provides this framework. The DSM-4, the current iteration of the DSM, uses a multi-axial system to classify and codify diagnosis. It should be noted that the DSM is not a means by which a psychologist diagnoses a patient, but the process used to code the diagnosis. This process yields a more complete diagnosis of the disorder by taking into account multiple factors. Axis 1 includes the major categories of disorders, such as schizophrenia and mood disorder. Axis 2 includes personality disorders and mental retardation. And these two axes help the psychologist to segregate out multiple facets of a disorder that may or may not be present. for example, major depressive disorder on axis 1 with alcohol abuse on axis 2. And obviously if both are present, they're going to affect each other. Axis 3 includes medical conditions that might affect or interact with the psychological disorder itself, such as hypothyroidism or the presence of ongoing migraine headaches. And axis 4 is a rating of recent social and environmental sources of stress, such as a death in the family or chronic unemployment. And then axis 5 is a global assessment of functioning made on a scale that sort of ranges from 1 to 100, 100 representing unimpaired function and 1 would be very severe dysfunction. And so you can see on this multi-axial system that the DSM really utilizes the biopsychosocial perspective. Here's an example of how a therapist might make a complete DSM multi-diagnosis. Axis 1, we see alcohol dependence. On axis 2, we see dependent personality disorder, which is a particular kind of personality disorder. On axis 3, there's the presence of diabetes and a recent death of a spouse along with unemployment. And of course, all of these are going to interact with each other. Interestingly, in this particular case, the global assessment of functioning is 60, which is moderate. So when we say moderate symptoms, occasional panic attack, moderate difficulty in social, occupational, or school functioning, but not debilitating. There are some criticisms of the classification system that is currently being used. It relies heavily on a medical perspective, and not all psychologists like that approach. The reliability in diagnosis remains a problem. Disorders have sort of fuzzy borders. Some disorders look very similar. They share certain characteristics. And any given patient may exhibit some but not all of those characteristics of the disorder. And there's still a lot of controversy around what should be in or what should not be in the diagnostic manual. Dissociative identity disorder, previously known as multiple personalities, has always been questioned as to whether it's a real disorder or not, along with premenstrual syndrome is another case of should this be included in the manual or not. So that's basically our discussion on diagnosis and understanding the psychological disorders. We will now turn to look at specific types of disorders and what those look like, what those entail.